I'm Bobbi Fisher, and this is my Aesthetically Awkward podcast, a show where we dive into all things aesthetics, health, wellness, entrepreneurship, and everything in between. This podcast is for informational and entertainment purposes only. It is not medical advice. Please consult your own healthcare provider before making any decisions in your personal health journey. Now let's get into it. Today we are going to chat about melasma. You have heard me mention this if you've listened to any of my previous episodes. It's a very frustrating skin condition for those of us who suffer from it, and also for practitioners who treat it, because it doesn't behave like other sun damage or sunspots. It's a chronic disorder. It's reactive. It's heavily influenced by hormones, heat, inflammation, light exposure, and even if it does improve, all it takes is one backslide for things to quickly unravel and to have an exacerbation. It's a condition that I tell people it can be controlled but never cured. We're going to talk a little bit about the triggers, what causes melasma, who's more susceptible to it, and what you can do to help manage your melasma at home. Melasma is defined as an acquired hyperpigmentation disorder. It is typically a symmetric brown or even a gray tone to the skin, most prominent on sun-exposed areas of the face. So think the forehead, cheeks, upper lip. You'll hear it discussed in dermatological literature as chronic, relapsing. I never want to make false promises because we can help you address it, but what we are doing in clinic and even the skincare you're doing at home is only a part of it. Under the microscope, melasma will show increase in pigmentation in both the epidermis and the dermis, but we'll also see basement membrane disruption, solar elastosis, vascular changes, increased mast cells, and subclinical inflammation. Because of everything that's going on, no two patients will present exactly the same, and no two patients will necessarily respond to the exact same treatment plan. Sometimes it will be misclassified as post-inflammatory hyperpigmentation. That is something that usually follows an injury or an insult to the skin. Think like a post-acne mark, eczema, or even the pigment that you get on your skin after a burn heals. Sunspots are usually truly that, just a single uniform spot on the skin. Melasma does not present like that. It's usually more diffuse, more symmetric, and often linked to hormone disruption. It can almost sit like a shadow on the skin, and that's something that I specifically suffer from. I have dermal melasma. It's a shadow patch that's on my forehead. Depending on what treatments we're doing in clinic, we can help keep it controlled, but during times of inflammation, during stress, if I spend too much time outdoors, exposed to heat, do too many aggressive treatments in clinic, I will have exacerbation of my melasma. On my forehead, it'll also show up on my cheeks and on my upper lip. Some people will say that they feel like their skin's dirty. It looks like I've got dirt that's been rubbed on my face. Depending on the severity, some people have a real emotional burden from the way their melasma presents. They feel like they need to hide it. So we've defined melasma, irregular but often symmetric patches or shadows on the skin, forehead, cheeks, upper lip, even on the nose or the chin. When it's on the cheeks, you'll hear it referred to as malar melasma. Mandibular melasma, it's less common, but it does exist, and that's usually the jawline that's affected. But the most common places for it to appear are the centrofacial, so the forehead, nose, the upper lip, or even the chin, and then the malar region or across the cheeks. Regardless of where it shows up, it can be distressing, but if you look at the literature, the upper lip is what most often is reported as having a negative impact on somebody's quality of life because it creates the appearance of a shadow or a mustache. And depending on your baseline skin color, it may present differently. Patients with darker skin types are going to have more of a gray-brown appearance or an ashy undertone in their melasma patches. Some patients improve quickly, others need a very long maintenance-focused strategy. Talk about the different variations of melasma. So epidermal versus dermal melasma. You can have both. Epidermal melasma, it just means that the excess pigment is sitting more superficially or in the epidermis layer of the skin. It tends to look more brown and may respond better to the topical treatments. So more superficial strategies like safe sun practices, wearing your SPF, that tends to respond pretty quickly. When it's deeply rooted in the dermal layer of the tissue, that is when it often has like a gray appearance or undertone. It may even look blue on some skin types. And then again, some patients can have a combination of dermal versus epidermal. In the literature, a Wood's lamp is usually used to estimate the pigment depth. Under a Wood's lamp, epidermal pigment tends to be a little more accentuated. We just purchased a
skin analysis machine, which is going to help us give patients a better clinical insight and imagery to document their before and after treatments and show us which layer of the skin their pigmentation is in. So I'm very excited about that. Melasma can affect anyone, but it overwhelmingly impacts women, especially women during their reproductive years. A recent analysis that I read of melasma clinical trials, more than 96% of the enrolled participants were female. It is seen more commonly in darker skin type patients, so Fitzpatrick skin types 3 through 6, and in patients with higher cumulative UV exposure. It doesn't mean that lighter skin patients can't get melasma, obviously. I'm proof of that. But the burden of melasma is significantly disproportionate with darker skin types. It often begins in the late 20s through the 40s and during pregnancy for females. For those of us who were impacted by melasma that flared during pregnancy, it was probably labeled as a cloasma or the mask of pregnancy. Sometimes it's only prevalent during pregnancy and then it does clear up. So key takeaway here. Hormones are a huge driver of melasma and overall inflammation in the body. Estrogen and progesterone signaling is generally implicated when we're thinking about melasma, which is why it's so common to see it flare during pregnancy. Genetics matter too. It is thought that melasma has a real hereditary component. Thyroid disease is another internal factor that's worth mentioning here. It's not as dominant in the literature, but thyroid abnormalities do show up in some of the melasma cohorts. There was another clinical study in 2024 that reported thyroid disorders in about 21% of participants. That's a pretty good percentage, and I also happen to have hypothyroidism. Then the discussion of overall inflammation. Think back to when we started this episode, we mentioned mast cell involvement, inflammatory mediators, basement membrane disruption, vascular changes in melasma-prone skin. The pigment pathway is influenced by more than just melanocytes. Inflammation intensifies that signaling, deepens the persistence, and worsens the recurrence of melasma. And that's why harsh treatment plans often backfire. Fully ablative lasers, aggressive heat, it causes too much irritation, too much barrier disruption, and you end up feeding that inflammatory loop that keeps the pigment active. And this is really a non-negotiable for all of my patients in clinic, whether you do or don't have melasma anyway. Chronic sun exposure is consistently identified as a trigger. Why? UV exposure stimulates melanogenesis, contributes to oxidative stress, worsens dermal damage, and it helps maintain your relapse cycle. You can spend thousands of dollars on topical skincare regimens, on SPF, on procedures, but if you're not reapplying that SPF, if you're not intentionally avoiding UV exposure, you're going to have a relapse. Randomized controlled trials in melasma demonstrate that sunscreens protecting against both UV and visible light outperform UV-only sunscreen. That's why tinted mineral sunscreens with iron oxides are so important to use. It's not just a cosmetic preference, it's a strategic part of pigment management. It's not just about direct sun exposure, but thermal exposure, the actual heat that you're being exposed to. So the skin getting heated up by the sun or taking hot showers, being in a sauna, heat from outdoor activities, getting your heart rate up, hard workouts, going on that run, even cooking, steam hitting your face, that can aggravate pigment. And that's why some patients continue to get flares. Overexfoliation, poorly chosen acids or topicals, inappropriate lasers, aggressive settings, repetitively injuring your skin barrier can worsen your pigmentation. Tyrosinase inhibition, antioxidant support, and inflammatory support are important, as well as barrier preservation. That means we want to reduce pigment production, calm the oxidative stress, limit irritation, and support a healthier skin barrier. We want to reduce irritation. We don't want to worsen the dyschromia or the pigmentation. So if you're using a topical that burns, that stings, that makes your skin feel inflamed, the ingredients might sound impressive, but they're actually backfiring. Some of the products that we like to use in our clinic that are over-the-counter: Skin Better Science, the Even Intensive, the Glow Tone by Face Reality, Epicutis Arctigen and Brightening Serum, and then the Epicutis Lipid Serum for helping cool the skin and to reduce inflammation. The best thing you can do is book a skin consultation with one of our estheticians. Prescription topicals are also available. Hydroquinone remains one of the most studied depigmenting agents for melasma, and systematic reviews continue to support the use of it in combination therapy, usually a triple therapy with hydroquinone, a retinoid, and a corticosteroid to help keep inflammation at bay. It's really important to go to somebody who helps counsel and guide you on using these types of therapies, though. So often providers will write for them, but they don't give any education. Patients will lather a thick layer on, and they will get rebound, burning, or peeling. What did we say earlier in the episode? Inflammation is a driving factor. Well, if you're stinging and you're burning and you're peeling, you're chasing your tail here. It is not going to work. Melasma, the evidence that your skin's learned to overreact to an underlying trigger. So even if we lighten it, try to brighten it back up, your skin remembers how to make that pigment. And that's why people will say, I got rid of it, but it came back. Controlling your internal and your external factors, avoiding heat, wearing your SPF, keeping internal inflammation at bay. Go to a provider who respects that you have melasma and uses treatments that are appropriate for your skin type. Using the appropriate topicals to regulate your pigment, to slow down how much pigment is actually being made by your skin, and then layering in treatments like the Pico laser, like an appropriate chemical peel such as the VI Peel Precision Plus. Book with a clinic that can help you understand what's going on with your skin, help coach you on your triggers, help create a treatment plan, a roadmap for you, commit to that roadmap, to those treatments, to those lifestyle changes, to your home regimen, get it under control, and learn to identify those triggers so you can help try to reduce the risk of it coming back. That's all I have for you today. If you enjoyed the episode, please leave a review. Leave a comment if you have any questions, or slide into my DMs over on Instagram. You can follow along at Aesthetically Awkward Podcast. I'll talk to you next week.